The blood's trying to get out of your heart, but it's hitting a brick wall. We're continuing our hemodynamics series. Today we're going to talk a little bit more about afterload. My name is Leah. I've been a CVSU nurse for 18 years. And today let's chat through afterload. So if you have a patient and you're talking about afterload, the thing that you're going to think about the most if you've worked with hemodynamics is SVR, systemic vascular resistance. It's how at the bedside we measure the patient's afterload. Afterload is the resistance the blood has to overcome to get out of the heart. Whenever we have a patient that has an afterload that is higher than 1200, we know that that's an increased afterload. And if it's lower than 800, that's a decreased afterload. We may see an increased afterload if our patient is releasing things like catecholamines that are increasing the blood pressure, if the patient's on vasopressors, natural release of things like vasopressin, or if we're giving the patient vasopressin. We will also see that in a patient whose cardiac output is falling, if they don't have enough preload, the patient will try to compensate for low preload by increasing their SVR to get an adequate cardiac output. The most common causes of decreased afterload are vasodilation, often caused by medications that have been given, and conditions like sepsis. So if you see the range 800 to 1200 in your patients in there and their cardiac output's gravy, don't worry about it. If you see a patient whose cardiac output and MAP are great and their SVR is slightly out of those ranges, you're not going to try to correct that as long as their cardiac output and their MAP and their perfusion looks good. However, if you have a patient that has a high SVR that is decreasing their cardiac output, what kind of things would you be thinking about as a bedside nurse that are at your disposal to do? The first thing is assess your patient and see if your patient is having pain. If the patient's having pain, they're going to have vasoconstriction, and then they are going to have an increased SVR, which is going to decrease their cardiac output. So you could do interventions like give the patient a little bit of morphine if they have like a 2 or 4 milligram dose and that's appropriate for them. You'll probably see that help. If you know that it's because the patient's preload is low and they're trying to compensate from that, and you can see that from the PA diastolic, CVP, SVV, then you could give the patient some volume and see if that fixes the issue with the increased afterload. If it doesn't, you can address the afterload a little bit more, but you would want to kind of get that root cause first. If you are seeing an increased SVR and your patient's temperature is like 94, 95, try to warm your patient up. Vasoconstriction from being cold can cause an increased SVR as well. Medication-wise, to decrease SVR, we often use medications such as nicardipine. We used to use a medication called nipride frequently. I'm not really seeing it anymore. And if the patient's SVR is too low, then we would use medications like pressors to increase that. So continue to follow along this hemodynamics series, and we'll continue to talk about all things hemodynamics.